So good afternoon, everyone. Welcome to the 2020 School of Medicine Full Faculty Meeting, co-hosted by the Faculty Council and the Academic Senate. My name is Jialin Liu, the chair of the School of Medicine Faculty Council this year, and I will be accompanied by our panelists, Dr. Matthew Ammons, Matthew, and Marta Margera. Marta.
Hi.
And today we're gonna together welcome our speaker, Dr. Carrie Byington, to talk to us about the COVID response and recovery. I also would like to acknowledge the presence of a lot of support. First is Christy Tappan, our Senate analyst, and the crew of IT and logistics support, Joey Chen, Amber Corbett, Todd, and Ken. So for those who have never heard of us, allow me for a moment for a short introduction of the School of Medicine Council, which is the committee under the Academic Senate. So the general function of our council is to act on behalf of the faculty with respect to any of the subject delegated to us by the faculty. In other words, we are your representatives. So please come to us with your issues, concerns, suggestions, and give us your feedbacks. So in another direction, we serve as an advisory role and make recommendations to the UCSF leadership when we are called upon for any particular issue that requires attention. So first of all, our council has dedicated responsibility that when it comes to medical education and the faculty development. Each year, we are charged with the responsibility of appointing members of 4 standing committees, including CCEP, Committee on Admission, Academic Progress, and Academic Standards. We're also responsible for the review and the funding of the Chancellor's Faculty Learning and Development Award, which is a funding mechanism to support skill and professional training, particularly supporting the activities that can benefit the peers and the trainees. So the individual award is capped at $5,000. If you're interested, you can find details of this award on our website. Next slide, please. So School of Medicine Faculty Council is comprised of 10 elected faculty members representing 5 different faculty series and 1 representative from UCSF Fresno, plus 5 members of the ex-officio members. The current membership of the council includes myself, Matthew Ammons, Rena Fox, Seema Gandhi, Marta Margera, Priya Prasad, and Christopher Schreiner, and most importantly, Christy Tappan, our analyst, who is doing the heavy lifting of organization and record keeping. So her contribution really allow us to do our daily job in addition to being a council member. So the ex-officio members, including the Dean, the Vice Dean for Education, Vice Dean for Academic Affairs, Associate Dean for Graduate Medical Education, and the Chair of the Committee on the Curriculum and Education Policy. For the coming year, Matthew Ammons and Marta Margera will step up to become the Chair and the Vice Chair, respectively. So the council is also in the process of recruiting more members to fill the vacancy. If you're interested in serving, please contact Christy Tappan. Next slide. Lastly, I would like to mention a few highlights of our effort in 2020. So we have a number of focus areas. First, we wanted to promote transparency and enhance faculty performance. We investigate the policies regarding appointments, serious compensation benefit, and promotion criteria. We wanted to facilitate faculty research. For this, we work with the Office of Research and RMS. We identify funding mechanisms, opportunities, and we make the resources available for grant writing. There are a lot of grant templates, and we promote collaborations between groups and campuses. We also are interested in improve the faculty well-being. We try to identify stressors as well as resources to mitigate faculty stress. And all these information and the topics and the discussion points are available in our website. Lastly, we funded a total of 22 applications out of the 43 for the Chancellor's Award, and it's totaling close to $80,000. So each year, the Faculty Council holds a full faculty meeting in the format of a town hall, like what we have today, to share with you about the Council's important work, as well as the major issues we attempt to address. So it's an opportunity for everyone to ask questions and engage in discussions. As you may recall, last year, we had a very productive discussion about how to promote diversity and equity in UCSF community. This year, the main topic would be about how to, will be the role and involvement of UCSF Health on COVID-19 response and recovery. We have the privilege to have Dr. Carrie Byington, the Executive Vice President of the UC Health, as our speaker. Dr. Byington received her bachelor's degree in biology from Texas A&M University and MD from Baylor, both with honors. She was trained in pediatrics at Texas Children's Hospital and her fellowship in pediatric infectious disease here at UCSF. She's board certified in general pediatrics and pediatric infectious diseases. Prior to her joining the Texas A&M, Dr. Byington spent more than 20 years in teaching and leadership positions with the University of Utah, including serving as Associate Vice President, Faculty and Academic Affairs with the University of Utah Health Science Center and Principal Investigators for the Utah Center for Clinical and Translational Sciences. However, for most of her career, she has been a physician scientist herself. Her research focused on viral and bacterial infections in infants and children. During her years at the University of Utah, she and her colleagues had success in developing diagnostics tools for pediatric febrile disease. Her research portfolio has reached $80 million in total, including funding from NIH and the CDC. Her expertise and authority in the diagnostics and epidemiology of the pediatric infectious disease actually give her the current role in UC Health. Dr. Byington's career accomplishment is very well recognized by the long list of awards she received, including those from the Robert Wood Johnson Foundation, the American Academy of Pediatrics, CDC, NIH, and lastly, Drexel University College of Medicine Institute for Women's Health and Leadership. Without further ado, I hand over to Dr. Byington for the talk.
Thank you so much, Jialing, and thank you to the entire Academic Council. It's really a pleasure to be with you all today and to talk about COVID-19. And this is our third attempt to have this meeting, and so I'm so grateful that it worked out. As Jialing said, I was a UCSF fellow in pediatric infectious diseases and am thrilled to now be a UCSF faculty member. So it really gives me great pleasure to meet with the faculty here today. If I could get my first slide, we'll go ahead and get started. Great. Thank you very much. And as we start, I just want to give a little bit of a background of UC Health. And I found on my visits across the campuses, a lot of times when I talk to faculty, they're not certain what UC Health is. They certainly understand their own campus very well, but what is UC Health? And I would say that we're in a process of growing and developing that, and that COVID is helping us along the way. So I've been at UC Health since October 31st. Maybe I should be careful having a start date on Halloween. That might be why this year's been so scary. I don't know, but anyway, I started on October 31st and began to go and meet people across the system. May I have the next slide, please? And our system is quite large. And so the University of California Health is part of the Office of the President, and we work together with all of our health campuses. That includes 19 health professional schools, and you can see the types of health professional schools that train about 15,000 students across the system. We have 6 medical schools. UCSF, of course, is one of those, dentistry schools, nursing, and thousands of faculty, physicians, nurses that practice within our facilities. We have 12 hospitals with almost 4,000 beds. And last year we had about 175,000 admissions, inpatient admissions, and 7.5, almost 8 million outpatient visits. We have resources that I would say are unparalleled in the United States. All 5 of our academic medical centers are NCI designated comprehensive cancer centers, and we have 5 NIH CTSA award sites, again in those same academic centers. I had the privilege of being a CTSA PI at the University of Utah, and really am a fan of that organization. And working here, we have 5 of those CTSAs that link together through a common entity called UC Braid. And so that's been very, very remarkable to get to know. We treat some of the most ill patients in California, and we all are on Epic for our healthcare, though not all of us are on the same instance of Epic, but we have been able to create one secure data warehouse for the entire system that has approximately 200 million encounters in it. So a remarkable resource for research. We train 2/3 of the medical students in California and 1/2 of the residents in California. And last but not least, have about $2 billion in NIH funding. So it is a remarkable system, a jewel really for California and for the nation. Next slide, please. You all may have seen the rankings that were just released earlier this week on the 28th, Best Hospitals, US News and World Report. This may not be our most favorite ranking. There are many rankings that we value, but it is wonderful when you see the excellence across our entire system. So all of our medical centers are on the Best Hospitals in California rankings, and 2 of our hospitals, UCSF of course, and UCLA, are nationally ranked and on the honor roll of Best Hospitals in the United States. So again, a remarkable achievement throughout the system. Next slide. So as I said, when I came in October and I started visiting the different campuses, I was struck by what we could do to feel more like a system. And for me, I always go back to values first, that if we are going to work together and function together as a system, we need to share the same values. And so when I interviewed, I said that would be one of the first things that I would want to do would be to engage in a values exercise. And remarkably, when I arrived, the University of California Office of the President was working on a values exercise for the Office of the President and to really define the core values. And they published these in January of 2020. UC Health, working with much of the leadership across the campuses, was able to craft and put our mark on some of these values. And I think all of you would embrace these values of accountability, collaboration, diversity and inclusion, excellence, innovation, integrity, and being mission driven. The text in red that you see throughout is text that was contributed by UC Health, saying that we really wanted to foster a system that delivers superior outcomes. And for us, that's outcomes in clinical care, in education, and in service to our community. We foster teamwork and, where appropriate, systemness. Systemness has been a word that's been used across UC Health for about a decade, trying to act more like a system. And now we've placed it into the entire UC Office of the President values. We also, UC Health had values around innovation, but the Office of the President did not. And so we were able to include innovation in the Office of the President value statement, and we added language around that, including that we accept risk-taking as an opportunity to learn. If we're going to innovate, we have to be willing to take risks and to learn from those experiences. And then diversity and inclusion is at the forefront certainly today, and we added the language that we embrace diversity, equity, tolerance, and inclusion in all forms. That came directly from our UC Health values. So I was really excited to have these values, and I brought them to our UC Health leadership retreat, which occurred in December of 2019. On December 11th and 12th of 2019. Next slide, please. And we use these values to inform system-wide goals that might require collective action. What could we work on together that we could advance in ways that we couldn't do as an individual campus or location? So in that December 2019 retreat, we crafted 3 system-wide goals across the leadership of all of the campuses, including the chancellors, the vice chancellors for health, the CEOs, and faculty representatives. So the first goal is to improve the health of all people living in California now and in the future. The future was added to really try to emphasize the research component that we have, trying to make things better in the future. The second goal was to promote health equity through the elimination of health disparities. And finally, the third, to reduce barriers to access to our clinical, education, and research programs by creating more inclusive opportunities for employees, students, and trainees. And that was where we ended the year in 2019. Next slide, please. And as I said, there has been this journey of systemness since about 2008 with my predecessor, Jack Stobo, looking initially at really how they could, how the campuses could manage contracts, how they could leverage their scale to get better contracting rates. They then started looking at quality initiatives across the UC system, and we set quality goals through your chief medical officers each year and chief nursing officers, and we try to meet those goals. There's been some remarkable work around diabetes and hypertension. We then started looking as a system at cost reduction and again leveraging scale for value so that we could get better contractual arrangements on our supplies, on our equipment, on many of the things that we purchased, and including drugs, pharmaceuticals, to lower the cost of delivering care. We then began to look at a Medi-Cal strategy to be able to provide more healthcare for the Medi-Cal population, and then begin to look at other areas where we might work together, like building consortia, cancer consortia, and others. And that's really where where I came into the organization, there had been this increased focus on systemness. And right here, we had done a lot, and there were still many more opportunities, potential in the area of clinical care delivery, and we have not really begun to tap the area of education and research. And so that's where I was planning to focus at the end of that retreat in December of 2019. Next slide, please. So one of the areas of focus was to stand up a cancer consortium, a UC Health branded cancer consortium for research and clinical care. And why would that be a good idea? I'm just going to show this slide, which I think is so impressive. This is 2018 data showing NIH, specifically National Cancer Institute funding for many well-recognized organizations, Stanford, Mayo Clinic, Hopkins, MD Anderson, Dana-Farber. These are the top funded cancer organizations in the United States. If you look at UC, each one of us individually, we would be further down the graph. But if you look at us together, we're almost twice any other organization. And so how do we leverage that scale to do more research, to do better research, and to improve the care for individuals? So as part of our cancer initiative, we have now cataloged all of our clinical trials in cancer, and there are over 1,000 clinical trials being offered in cancer across the UC system. Can we coordinate it so that if a patient in San Diego needs a trial in San Francisco, they can be admitted? What can we do for virtual trials and virtual enrollment? So this was one of my goals, again, in December of 19. Next slide, please. And in December of 19, we really wanted to optimize our UC Health data warehouse. This is a data warehouse where all of the individual campuses feed data in. These are all different instances of Epic, but they feed into a single electronic data warehouse. It has excellent data security, and it's used for many things across the organization, including our quality measures, our self-funded health plans, etc. And so we had a lot to work on. We had new values that had been articulated. We had system-wide goals, and we were going to focus on our cancer consortium and optimizing our health data warehouse. Next slide. And then on December 31st, just about 20 days after our retreat, the world became aware of COVID-19. I like this piece of a poem that comes from Jane Hirschfeld. It's really resonated with me during COVID-19, and you all had the good fortune of having her as your poet in residence in 2017. One day I hope I can meet her. Her poetry is lovely. But the entire focus then of UC Health really turned on January 1st of 2020. And we haven't lost sight of the Cancer Consortium, and we certainly haven't lost sight of our UC Health data warehouse, but our focus has been almost exclusively on COVID. Next slide. So immediately upon hearing about this novel coronavirus, and I think all of us will remember where we were. As an infectious disease physician and someone who has worked in trying to develop diagnostic technology that would allow earlier recognition of pandemics, I'm very attuned to new viruses, and I heard about it on the radio December 31st as I was, listening to NPR and brushing my teeth and getting ready for the day. I heard about this virus, and it raised all kinds of alarms. On January 1st, I talked to President Napolitano to ask her what types of emergency response and preparedness might exist at UC. Remember, I was still very new and within the first 60 days. And then the next call was to Atul Butte, to talk about data. You know, what are we going to do? How are we going to be able to track data? And Atul, all of you know him. He may be on the call. On the chat. I don't know. Exceptional professor and data expert. And we were able to talk about how can we leverage the electronic data warehouse to capture COVID patients and to have some better understanding and overview of the pandemic. And so this is just one data capture that we publish every day. You can see it on the UC Health Twitter feed, on my Twitter feed, on Atul's Twitter feed. This is obviously a map of California. Each dot represents a patient that we've cared for and where they come from, what zip code they have. And you clearly see clusters of patients here in San Francisco, Davis, Los Angeles, Irvine, and San Diego. But you see dots everywhere in the state, all throughout the state, and even in states outside of California. And if we showed the entire map, you'd even see people, all over the United States. We are a referral center, and this helps us understand, where are our patients coming from, who's taking care of them, which patients are we being asked to receive and transfer, and where potential hotspots are. So to date, we've tested more than 170,000. I think by next week, we'll be getting close to testing 200,000 patients. We've done about the same again in testing people for public health, testing people in special circumstances like homeless shelters or skilled nursing facilities. So we've done a lot of COVID testing. We've cared for more than 6,000. Again, I think it will be close to 7,000 by next week. Patients who've been positive for SARS-CoV-2. Most of them are outpatients, but we've cared for almost 2,000 inpatients and have more than 200 patients admitted today. And we've had about 130 to 140, I think the number today might be 142 deaths so far across our system. So it's been really useful for us to be able to track these data, and we share them amongst ourselves each day and with leadership at each of the organizations. The CEOs and vice chancellors every day see these data, and so do the people who are leading the incident command centers across each campus. Next slide. So this is from a couple days ago. I prepared it for the Board of Regents, but it shows you the pandemic really from the beginning to where we are today. And I would say it was harder on the far left when we just had a handful of patients and we were rapidly trying to understand everything we could about the virus. The care of these patients was quite expensive as we were building new sites for them. We were trying to build new laboratory facilities. We then went through the spring surge and kind of peaked at about 170 patients each day, 150, 170 patients each day across the system. That's the top line that shows all of the patients, and then the individual colored lines represent each campus, and UCSF is green. But that was the spring, and what you see now today in July is another surge, and it's far worse than the surge in the spring. And I'm really extraordinarily proud of our healthcare system and being able to care for this large number of patients while at the same time providing essential care for other conditions, non-COVID conditions. We've had to learn to care for cancer patients while COVID is in the facility. We have to learn to do surgery while COVID is in the facility. So it's just really been an extraordinary growing experience. And I personally am planning for the fall and winter. I think we'll see higher numbers than this potentially, and we will be dealing with other winter respiratory viruses like influenza. So for all of you who are seeing patients and caring for patients, there's no way that I can thank you enough for the work that you've done in San Francisco, for the teams that have gone to New York, to the Navajo Nation, to South Texas, to Southern California. Your work is inspirational, and it is saving lives all over the state and nation. So thank you so much. Next slide. And we do want to be very transparent. We're a public institution, and so we were one of the first institutions to start sharing our data on social media. And you can usually find it at University of California Health, usually by 1 or 2 o'clock in the afternoon. My Twitter will be somewhat later. I usually do it in the evening when I'm finishing up for the day. But we're trying to share these data as widely as possible. And I thought this number was very impressive. In the first 90 days, our Twitter feed for these data had 1.8 million impressions. People are following from all over California and all over the country. Our data are used for models. They're used to inform CDC and FDA. So it's really making a contribution. Next slide, please. So after data, my next phone call was really to lab. And I'm a laboratory person. I've developed laboratory testing that's used in the United States and in other countries. And I've been involved with the H1N1 pandemic, Zika, and Ebola, and had been involved in standing up FDA emergency use authorized tests for those outbreaks. So I really knew what we needed to do and called our laboratory people together. I was so gratified to find out that we had a laboratory working group across the system led by Dr. Steve Gonius at UC San Diego. The laboratory science people from all of our campuses are involved in that group. And immediately this group began to take action to prepare. And the first thing that needed to happen was to develop our own laboratory derived tests and to advocate hard at CDC and FDA to get permission to use these tests. I would have liked to have seen that permission come in January. It did not come until February the 29th, but within 12 days, all clinical labs, all CLIA labs across the UC system were offering COVID testing for our patients. Next slide, please. This just shows some of the labs that were involved, and the collaboration and cooperation between the laboratory specialists across our campuses was fantastic. And people were sharing patient-derived materials, sharing sequence information, helping each other to develop the best tests that they could. And so our first step was, to coordinate with public health, to develop our own laboratory-derived tests, get them approved, start offering testing, and then to work with the commercial vendors to bring different platforms online so we could raise our diagnostic testing to scale. So where we started in March was probably about 200 tests a day across the system. That went up very quickly, and we now have a capacity across the system to do about 10,000 tests a day in our clinical labs, and even more tests using basic science labs that have been stood up across the system, including the BioHub here at the University of California, San Francisco, which is doing probably 2,000 to 3,000 tests a day. Our clinical labs have been instrumental in helping the basic science labs stand up their facilities and get CLIA certification. So it's really been remarkable. Next slide, please. So working with data and working with the labs, it became clear to me that bringing the experts from each campus together was valuable and was helping the system to do big things and to better respond to the pandemic. So in February, late February, I went to President Napolitano and Rachel Nava, her Chief Operating Officer, and said, you know, there are so many decisions that need to be made. The management response team for UC is used to doing emergencies like an earthquake or a fire that happens at a single location and it happens for just a short time. And this pandemic is happening everywhere, every day, and it's going to be, you know, part of our life for the next 2 or 3 years. And it would behoove us to have a management response team that's dedicated to health and to the pandemic. And so she authorized the creation of the University of California Health Coordinating Committee for COVID-19 on March the 18th. And we stood that committee up. Next slide. This is where we fit within the organizational chart. Our UC Health Coordinating Committee reports up to the management response team and then directly to the president and to the chancellors on all campuses, and including the national labs. We'll change this slide soon because it'll say President Michael Drake. Today is President Napolitano's last day. This coordinating committee, I take input, I chair the committee, I have an executive steering group, and we have representation from every campus on these committees. And I take input from the CEOs of the hospitals, existing system-wide groups like our chief medical officers and chief nursing officers, occupational health, emergency managers, supply chain, et cetera. When they have an issue that's health related and they want a system-wide plan, then it comes to us. We created subject matter expert groups, and that's been honestly extraordinary. I have not issued a single call for subject matter expert that I did not get overwhelming response from every campus. And so we have a number of subject matter expert groups. They're listed here: public health, infectious diseases, laboratory medicine, education, telehealth, bioethics, and clinical research. The amount of work product that has come in just a few months from these groups is extraordinary. And again, the depth, these are some of the, in their fields, they're national and international leaders, and they're contributing their time to ensure that we have the best possible response. We started first with a response for the hospitals and the hospital system. And in about late April, the president charged us to begin assisting the campuses on their resumption activities and planning for the fall resumption. And so that also has taken a huge amount of our time. Next slide, please. And so you can see some of the output on the websites, and I'd like to, you know, for those who are interested, some of the things that we did, we developed principles for opening the hospitals, for resumption of care in the hospitals in the late spring after that initial surge. Next slide. And we had coordination with the Board of Regents and our campuses for setting consensus standards for what would be the standards for resuming in-person activities on our campuses. And so this was in later May after the hospitals. And so we had groups in all of these different areas, coordinating with state and local health, having a phase plan, being able to do risk assessment, health screening, housing, etc. And UC Health was then further charged with that number 4 bullet, really finding a way to make a plan for testing and contact tracing for our entire system. Next slide, please. And so today, you can see all of the guidance that we've published on the UC Health website under reports and resources, and it'll say the UCH Coordinating Committee. And I've put the link there. So you can read the documents that have been developed. They've been written by faculty and staff across all the campuses. And the other thing that I will point out is I send out a Regents update um, very regularly. At the beginning of the pandemic, I was doing it weekly. Now it's every 2 weeks, but they are also archived here if you'd like to see my updates to the Board of Regents. I try to highlight issues related to the pandemic and issues related to UC, but also really highlight the excellent work that's happening across all domains at UC Health. So clinical, education, and research. And so it is a nice archive to read about the work of your colleagues. And there's usually a section on there that I call Heroes of the Pandemic. So that's good to look at too. So next slide, please. So just a few things that have come out, if you're not aware of them. Our Bioethics Committee was pulled together from across the system to help us in developing crisis standards of care and allocation of scarce resources. And so for those of you who practice, you know we usually practice under conventional care, normal staffing, normal space, normal supplies, it's usual care. And if we have a shortage of something, we may need to do contingency care, but usually it's just in one domain. If you have a shortage of one antibiotic, you have a contingency plan and you use a second antibiotic. But what we were dealing with was being prepared for crisis care. Early in the pandemic, we did not know what California would look like, but we were predicted to be, you know, the major hotspot of the United States, given our location on the Pacific coast and the amount of travel occurring in Asia and to the United States. We really were expecting to be New York City, and instead we weren't. And thank goodness the interventions of the governor, many of which were informed by UC faculty and staff, we were able to crush that first curve, and that gave us a lot of time to prepare our system. Next slide. So these are the allocation of scarce critical resources under crisis standards of care. They were published and shared with the regents and with the chancellors, the president, April 16th of 2020. This group is led by Rochelle Dicker, who is at UCLA, but was a former UCSF faculty member. And I know this group is working on publishing it nationally. We think these standards are really the standards that the nation should adopt, as we worked very hard to make sure that they were free of bias, particularly bias against the elderly or the disabled. So there was a lot of work to make sure that these were equitable standards. And so we're very proud of this work product. Next slide, please. Next slide, we'll go through there. Okay, so the other thing that we did was work with UC Braid for clinical trials. As you can imagine, there are lots and lots of opportunities for clinical trials, and we have a limited number of patients. And so it's been useful to talk as a group about which clinical trials seem to be the most promising or the most important for us to participate in, so that we can recruit and get new therapeutics FDA approved and in use. So we used Braid to help us coordinate the remdesivir trials, and we were able to have patients recruited from every medical center in the campus. And as you know, remdesivir was the first drug to get FDA EUA approval. We did the same with plasma, so convalescent plasma, working together to coordinate and get our campuses participating with the large Johns Hopkins trials. We had a lot of discussion. Is it better to, you know, partner or be on our own? We ultimately decided to partner, and so that's moving forward. And this is a mechanism that will serve us for the vaccine trials as well. We are starting this week with the Moderna vaccine trials, and enrollment is starting nationally, and the Southern California sites were selected for the Moderna trial. AstraZeneca is next, and UCSF is one of the sites for AstraZeneca. I had a meeting with Pfizer yesterday, and we're meeting with Johnson & Johnson. We want to contribute to the vaccine trials, and we want to ensure that there's a diverse patient population that's enrolled in the vaccine trials. Next slide, please. There's remdesivir. We were able to get IRBs, coordinated, and then you can see along the side, the far right side, these are the current clinical trials that are ongoing across the UC system. We keep track of the trials, the number of participants, those types of things, and where they're being done. Next slide, please. There's the plasma. And so not only are we participating in plasma trials and enrolling patients, but two of our sites, UCLA and UC Irvine, became plasma donation centers for COVID-19. And that's been very useful. And through the coordinating committee, we've been able to move plasma from UCLA or UC Irvine to other sites across the system when patients have needed that resource. So that's been very useful. Next slide, please. And then a tool, if he's on, would comment, but we have put all of our COVID information into a single COVID research data set that's updated each day called UC Chords. These data are from about a week ago, so there will be more patients in now. But one of the really great things is by working as a system is that this data set has received IRB approval from every IRB in our system, so all 10 IRBs. It's HIPAA compliant and de-identified, and so any faculty member can use this data set without applying for new IRB approval. So that's really going to be a benefit as you think about your own research. Next slide, please. And I've just circled here your contact person to access UC Chords if you're interested in training on how to use it and to use it for your own research. Hundreds of investigators across the system are being trained on UC Chords. Next slide, please. We've also published guidance that has been useful around the country. This was a public health response to reduce SARS-CoV-2 spread during civil protesting. This was guidance made by our system-wide public health group. It was published on the UCLA Health website and picked up by all kinds of media and was widely circulated. Next slide, please. We also have really developed a telehealth network. There was a small telehealth presence in UC Health before the pandemic. That's what this slide shows. The data go back to January of 2019, and it is the gold bars that are telehealth and the blue bars that are in person. If you look at January 19, you have a hard time seeing the gold bar because it's so tiny. So out of the 500,000 or 600,000 ambulatory visits that we were doing each month, less than 5,000 were by telehealth before the pandemic. With the onset of the pandemic, our telehealth working group created a primary care infrastructure and a critical care infrastructure to serve our UC system. And they trained hundreds of physicians to be able to deliver telehealth. We've trained our medical students and residents to participate, and we've invested in a lot of infrastructure to be able to deliver telehealth visits. And what you see now in June 1st of 2020, you see thousands, hundreds of thousands of telehealth visits each month. And as our ambulatory visits increase, we're not decreasing our telehealth visits. So we are actually now doing more visits than we were before because we're doing both ambulatory and telehealth. I think my next slide might focus on the critical care. Let's see. Yeah, next slide, please. And so that critical care has also been very important. We've been able to provide critical care expertise to hospitals in Southern California, in the Imperial Valley, and other areas to help them manage their patients and help coordinate transfer of patients who need critical services like ECMO. So that has been a great resource, and we intend to further leverage this resource as we recover from the pandemic. So one of the other things that our coordinating committee does is we interface directly with California Department of Public Health and with the governor's office. And many of our experts, subject matter experts, are on task forces led by the governor, and we provide data to the public health departments, and we really try to coordinate, our response with public health. And I do believe that part of the early response that allowed us to bend that curve and to get more time really was a result of our subject matter experts, working hand in hand with California Department of Health and the governor's office in Sacramento. Next slide, please. We also take direction from the governor. And so the governor asked that we increase our surge capacity by 40%. And so working as a system, we added surge bed capacity across the entire system, and almost 1,400 beds, almost 1,500 beds. And we were able to meet the governor's request of a surge capacity of 40%. UCSF certainly was very much involved in that, with Mount Zion and St. Francis beds being added for COVID. Next slide, please. All right, I'm going to take just a little deep breath. You've heard all, I hope, what you would agree are the good things that have happened in response to COVID-19. Those things did not come without cost. And so I'm going to spend just a little time now talking about the financial health of our hospitals in the midst of COVID-19. So this is a slide that comes from the Association of American Medical Colleges and was from 2018 Medicare cost reports. And I think it's really helpful to have this in your mind as you think about days of cash on hand in a hospital setting. And it was remarkable to me that 16% of AAMC hospitals have negative days of cash on hand, and 40% have no more than 10 days of cash on hand. So 56% of hospitals going into COVID-19 had no reserve and are really, struggling. And this is going to be something that our country deals with for quite some time. We were more fortunate across UC Health in that all of our hospitals are between 60 and 90 days of cash on hand. So we're on this further end of the curve. We think it's very important as a public institution that we do have reserve for the emergency type situations that we are seeing now. And it's also a requirement for our bonding and for our facilities and the maintenance of our facilities and the security of our employees. So we went into the COVID-19 crisis better off than many, many hospitals in the United States. Next slide, please. Nevertheless, we have been impacted to a great extent. This graph that I'm showing right now is a monthly report that we create for the state, and we report our losses to the state each month, early in the month. The darker blue color are our medical centers, hospitals. The lighter blue color are our School of Medicine clinics. And then the gold color is the general campus, so the general operating campus. And there's some concern. I mean, when you look at this, it's concerning. Obviously, these are huge numbers. But there is some optimism on these graphs in that we lost the largest amount of dollars in April when we were essentially shut down for all non-essential care. We did a little bit better in May, a little bit better in June, and we expect to do a little bit better in July. There are still losses, and we're going to have to account for these losses. And when you add up all the health center and School of Medicine losses through June, we're at $1.15 billion in losses. This is going to be felt throughout our system, and I believe we have to work together as a system. The income of the hospitals is vital for the support of the health professional schools, and it's also vital for the support of the general campuses across the system. So we have to come together in planning for our recovery and building resilience into the system. Next slide, please. So this is a slide that we presented to the Board of Regents that shows you the dark line where we were before the pandemic and where we were predicted to go, out to 2023. And then the dotted line is where we are. And you see a best case and a worst case scenario in that dotted line and where we might be, over the next few years. I do not believe we're going to be at the best case scenario, but neither do I believe that we will be at the worst case scenario. I think we're going to be somewhere in the middle, and it is going to take us probably 5 years or so to get back to where we were, our previous trajectory, if we don't change. And I think if we do change and we are able to stabilize our revenue and our liquidity and address our risks, that we may be able to recover, more quickly. Part of that will mean, changing the way we do things. Telehealth is going to be a big part of that. And coming back to the Cancer Consortium, branding ourselves as an entire system and offering service lines that we don't offer right now, taking advantage of the disruption that's occurred, that's going to be really important. Next slide, please. Here is one of our most important numbers is, are we getting back to normal for our bed occupancy? And you can see the dramatic plunge, and we were, down 50–60% in mid-April, and we are coming back up. And these numbers just go to very early July, and they have us right at about 80%. I would say today, as we enter into August, we may be closer to 85%. We are coming back up, but life is different in the hospitals, and we have to do things differently. So, for example, scheduling procedures or operating rooms, you're not able to turn those around as fast as you were prior to COVID. There are new requirements for cleaning, new requirements for personal protective equipment that make it difficult to think that we're going to get back all the way to where we were very quickly. And so I think we have to look at new ways of delivering care as part of our recovery. Next slide, please. This shows you where we are with the CARES relief funding, COVID relief funding. So as I said, we've lost so far about $1.15 billion, and we have recovered $494 million through CARES funding that's been distributed. So about 43% of what we've lost, we have recovered through CARES funding. Next slide, please. Oh, I'm gonna I'm going to just say one more thing. We have potential to get additional CARES funding, and we have made a request for 165 million for FEMA funding as part of the recovery. So the other thing that happened besides communication and collaboration, throughout this pandemic, I have seen such a dedication to service. And to me, that was one of the areas that I really wanted to emphasize as part of being the EVP for UC Health. I believe public service is why we're here. And for those of us who are in medicine, that is clinical service. And so the examples that you all have set are just fantastic. Everyone has risen to this moment and is doing all they can to serve the populations that mean so very much to us in California and outside of California. So I really, again, want to give such gratitude and thanks to the people on these slides and every one of you that are, that I don't have a picture of. It's been remarkable. Next slide. And in this area as well. So the pandemic, I always tell people, sometimes people believe a pandemic comes as part of the apocalypse, and that language is interesting. Apocalypse, it comes from the Greek, and it means to reveal. And there is no question that pandemics are great revealers. And so all of us who have been in healthcare know that there have been huge disparities in inequities in healthcare for decades or centuries, but the pandemic has made it visible to everyone and has really invigorated a call across the nation to address these injustices. And I was so proud of the way all of the UCs responded. It was the reason that my talk was canceled because we were observing a day, in response to this. And so I hope that we will continue this momentum and that this commitment to ending health disparities, reducing health equities, standing up for Black lives, standing up for all lives in our country and our state. We are a public institution and we are dedicated to the health of all Californians. And I want that to be a continuing mission that comes out of COVID, even stronger than before the pandemic. So with that, I will thank you. I think that's my last slide. I will thank you all for your attention and would be very happy to answer any questions that you might have.
Thank you, Carrie. That was a really comprehensive review about UC's role in COVID and a lot of data about recovery. So now we are opening up the Q&A session, which will be moderated by Matt and Marta. Please direct your questions to them and I will hand it over to you.
Thank you, Jillian. So thus far, we're still waiting for a lot of questions to come in, but there was one question, Dr. Byington, and it had to do whether the slides will be available to share.
Absolutely. You can have these slides, so you can feel free to share them. I've shared these slides with the Board of Regents. These are public.
Okay, wonderful. So we will make sure that these slides are then available on the Academic Senate website. So perhaps while we're waiting for some questions from our audience to come in, maybe Matt, do you have some questions you'd like to pose?
Yeah, sure, if that's okay. Thank you for that nice talk, Dr. Byington, and for being flexible in your timing. A few questions that I had that came up during your talk, just while we're waiting for the Q&As to come through. We certainly had a second surge of our first wave of infections that seemed to coincide with, warmer weather which may just be sort of coincidental with changing, shelter in place rules and things like that. But that doesn't seem to really go along with, what we expect from our knowledge of the flu and things like that. Why do we think that there's going to be, or why do you think there's going to be another surge that comes through in the fall or winter?
Thank you for the question. When the novel coronavirus was first identified, there was some hope that it would have seasonality, and we know coronaviruses are fall and winter, and even data with this virus shows it prefers colder temperatures and lower humidity. But in a pandemic, it may take time for a virus to enter into a seasonal pattern. And so the hope that we would have seen decreased cases in the summer just did not pan out in the United States, or in the northern hemisphere, or in other countries. It may enter a seasonal cycle over the years. We'll have to wait and see. But one of the reasons that I think that we may see more cases is because it will be colder and the virus prefers it. We tend to be closer together during the winter. There may be less humidity in certain places. And I think that the country has already shown a limited tolerance for being locked down, and that there's going to be consistently more interaction, especially if we are bringing individuals back to school, either K through 12 or the university. And so I think more opportunities for disease transmission. Even though we have had a large wave, a huge wave in the United States, the majority of our population is not immune. And so we still have a very susceptible population. So I think this winter is a particular concern.
Okay, so some questions have started coming in. So we'll start with the first one here. What do you mean by new ways to deliver care beyond telemedicine?
Well, I like virtual care instead of telemedicine. I prefer to use virtual as the word. And so we have done care through telephone. We've done it through laptops, in a variety of virtual settings. In Texas, I was very active in trying to find new ways to do care for rural populations. And there really are quite innovative things that are being done, and that we might be able to consider as well. I was looking at self-driving ambulances that have tele-components, so that you could actually be discussing things with physicians, unmanned booths where people could go and access mental health care, or other laboratory testing, even get prescriptions dispensed in secure ways. So I think we have to be very creative and look at what people want. The patient satisfaction for telehealth or virtual care has been incredible. Patients really like it. And so what are other methods that we can use? How can we monitor patients at home with wearables or with other things? And how do we incorporate those visits into our electronic health records so that everyone can share and understand in the care? And I do think we're going to have to be creatively delivering care, closer to the communities that we service. So those are some of the ideas that I think about.
Thank you. We have another question here in regards to contact tracing. Two-part question. Part one, UC is taking a role in educating the contact tracers in California. What is the status of our training of contact tracers and our interaction with the county public health organizations doing the tracing? And the second question is, at what test positive rate is contact tracing going to be most practical given the wide range of SARS-CoV-2 prevalence county by county in California?
Yeah. So the first question, as you all know, George Rutherford, who is one of your faculty members, developed the curriculum for the Virtual Training Academy for California that's training tons of contact tracers with the state and local health departments. And I believe they either have reached their goal or close to reaching their goal of training 10,000 individuals for the state and local health departments. We are now, because they've reached that goal, we as a UC system are now working with the state and local health departments to train our own staff for contact investigation and working with our local health departments. And UCLA Extension Office has the Virtual Training Academy, and we're starting to train UC people as well. So I think we're going to need a large number of these individuals across the state if we're going to do contact tracing. But it may be that we're not able to train as many as we need. And I'm also very interested in virtual tools, tech tools that could help us gather some of the information and contact people so that we can move them as quickly as possible. Contact tracing is best done when the numbers are small. If any one of you have done contact tracing, one person with a case easily has 5, 6, 7 exposures, and being able to track down those 5 or 6 people and get them tested and get them the information they need and help them with their quarantine, that can be overwhelming. And so when you're having 10,000 cases a day, 50,000 individuals who might need to be contacted and assisted, it can be quite daunting. So I hope that we can get our test positivity rate down below 5% across the state, and that may make it more reasonable. And I also hope that we will train a lot of people and that we will look at technology to assist us with contact tracing.
So the next question is sort of a follow-up to the question that I asked before. It has to do with changes in the way we may need to make to increase efficiency. So the question is, thank you for your leadership at this time. What do you anticipate might not get done or get cut for UCSF Health given the financial loss and projects of continued loss?
Right. One of the things that I'm really struggling with right now, we know we need for the system as a whole, clinical business strategy. And that was something that was, up and ready to go. And now we have to kind of pull back. My own budget for UC Health was cut 3 separate times during the state budget planning. And so we're really looking at ways to combine forces with the campuses, to share positions, to keep building the expertise that we know that we need. And I have some hope that through collaboration, we can keep moving forward even on the activities that are not directly related to COVID. We really need to do that. So that's what we're working on. And I would say the Board of Regents, they understand our limited budget and they're trying to support us. And I'm very, very hopeful that our new president, Michael Drake, who is a physician, will understand, the needs of the health system and will prioritize them. So we'll see. But we are going to have to be very creative on these lean budgets.
This is somewhat of a follow-up question. In terms of virtual care and finances, it says that virtual care certainly has advantages in terms of access and particularly in our immediate situation. However, the way we are practicing now seems to place quite a bit of the burden on individual physicians working from home using our own equipment, our own high-speed internet accesses, with less of our typical types of clinical support, including staff members. Also, there are many vulnerable individuals who may not have access to video or telephone. While this may be a very good bridge, it may not be a great sufficient long-term plan. What is our plan to try and ensure that we don't overly rely on the individual physicians and on virtual care when it may not be as equitable?
I hear you, and I think that our goal is to make it as equitable as possible. So at all different levels, like advocating at the state level to ensure that citizens of California have access to the internet, have the bandwidth that they need so that they can get care is one thing that we're working on. And the telehealth working group is an exceptional group. They've spoken and shared some of their learnings at an international conference just last month. They are really aware of these issues. And again, coming together as a system, it's not enough to say UCSF is going to have telehealth and UC Davis is going to have telehealth. We need kind of an infrastructure and a branded UC Health way of doing virtual care. And we did talk about it at our retreat, July 17th, and we call it UC Care Everywhere. And well, there's still a little discussion. Is it going to be UC Care Everywhere or UC Care Anywhere? But either way, having that infrastructure that gives you the level of confidence as a provider that you have the right equipment, the right scheduling, the right resources that you need to manage your patient, that's our goal. And we don't have that yet. We've come a long way quickly, but there's more room to grow in that area.
Lost feeling whose turn it is, but so another question has to do with the potential impact on UC medical schools. So will there be that you know of, or at least when you think about it, there will be any changes in the sizes of classes, financial aid available to students, or anything like that?
So far, we haven't discussed any changes in the size of the classes, but I think all of us know that our medical schools do depend on financing coming from the hospitals. And so I think all of us are going to be dealing with budget cuts this year, and we need to find ways to recover so that we can meet all of our needs, our educational needs and our needs to provide care, for example, to underserved communities, Medi-Cal communities. We really have to become very efficient, and that's going to take a great deal of effort across the institution. I spend time talking to the CMOs, CNOs, chief medical officers, chief nursing officers, CEOs, the deans, the health professional deans. Everyone is looking at ways that we can innovate and create efficiencies.
Another question here, given all this talk about different types of sacrifices and our current financial situation, the pressures of childcare and difficulties with homeschooling, as well as working from home, do you have any advice for our faculty to help maintain morale?
I look to you all, and actually I was at San Diego last week, and they asked the same question about morale. This is the first job that I've ever had where I was not actively part of a medical staff and making rounds in the hospital every day. And so I feel somewhat disconnected from the medical providers. And I would really appreciate hearing from you all, what is it that you need at this stage in the pandemic and for the long haul? Early on, we were doing things like providing housing and providing meals and our medical students all across the system were offering childcare, and there were a lot of things that were being done very acutely. Now we know we're going to be doing this, you know, for the next 2 years, maybe longer. What are the systemic changes or supports that you need as faculty to get through this? My email is open, and I am wanting to hear from people. I don't want to propose something that people don't want. I'd rather that it be informed by the faculty themselves. What is it that you think that you need, and then how can we get there?
So perhaps for a slight change in pace or topic, there is a question: how will the UC actively support the initiative proposed by David Scorton of the AAMC?
Is this the initiative on COVID-19 that was published just this week, or which initiative are we talking about?
Well, I'm not sure, but I imagine that's the case. The question didn't provide any more detail than what I just read.
You know, we work very closely with the AAMC. I talk regularly with the different groups. I was on Council of Teaching Hospitals today, and so we're supportive of all of the AAMC's efforts, and will contribute to them in whatever way we can. I've been invited to talk about COVID by the AAMC at the Democratic National Convention on August the 19th. So they'll be asking questions there and talking about COVID and the role of academic medical centers in both planning and responding to pandemics. So I'll have an opportunity to speak directly to Dr. Scorton.
Another question here, will the UC Health cross-campus collaboration that's resulted from COVID enable subspecialists to cover other UC institutions? It is a challenge to individual hospitals that there may be limited subspecialist support, but there may be others with the relevant expertise at other UC hospitals. This would require cross-credentialing across UC hospitals, and it may be beneficial financially to individual hospitals and to UC Health overall.
Yes, that's an excellent question. And actually the telehealth collaborative is working very hard on that, and the critical care consortium has already done this. They have piloted cross-credentialing and actually run a case on one UC campus being managed by another UC campus. And we're working with Office of General Counsel to create a smoother process for cross-credentialing that would allow individuals at one UC campus, their credentials to be almost immediately recognized at another campus during a time of emergency. And even after the emergency is over, I think our entire telehealth network would benefit by you know, having providers at any campus schedule and have an appointment with a patient anywhere in California. So we are working on that through Office of General Counsel for cross-credentialing, and we're working on it through Student Health. And we have a proposal for a mental health virtual care network that would be across all 10 campuses and will probably be piloted on 4 campuses this year that would involve some of that cross-credentialing. So yeah, definitely we're working on that.
And perhaps in the same spirit, what are your thoughts on creating one UC Health formulary to unify the 5 UC Health systems? What are the advantages and challenges that you anticipate with such an endeavor?
I would love to do that. So this group should know that I spent 21 years in Utah, at the University of Utah and in the Intermountain Health System. For those of you who are in health services, you already know Intermountain has 22 hospitals. They've shared a single electronic health record since 1976. And they have a single formulary, single purchasing, single everything. It results in huge efficiencies and excellent quality, and lowers cost. The biggest barriers to that are individual physician preference and individual campus preference. And in some ways, the excellence of all of our campuses can sometimes can sometimes be a barrier for collaboration. UCSF is excellent. UCLA is excellent. And so why should you have to change? Or why would you want to change? And so for me, those changes are important for the outcomes of our patients, and they're important for the outcomes of our system, because unnecessary variation is usually not a good thing and is always more expensive. And so I hope that we can use the collaboration that's been built during COVID-19 to see more of this working together as a system. And for me, data needs to drive it. And so in the area of formulary, there's a lot of work going on, but one of the first projects was looking at intravenous acetaminophen. Intravenous acetaminophen is extraordinarily expensive and would be almost never required. I'm a pediatrician. Tylenol, acetaminophen is probably one of the most frequently prescribed drugs in pediatrics. I didn't even know there was an intravenous form, and it costs thousands of dollars to administer it. We were using a lot of it in the UC system until we showed the data to our CEOs and to our chief medical officers, and a tool butte could even say which unit was using it, which doctor was using it, and we're not using it anymore. So we can come together on things that make sense. And we may never have a single UC formulary or a single UC charge master, but I think we could get a lot closer.
If there's no other questions, I would like to thank Dr. Byington for the wonderful talk and the full support of the Senate staff and moderator Mata and Matt. So thank you for this town hall meeting. And if you have any questions you would like to direct to this specific presentation, please send the questions to Christy. If you have any questions regarding the Faculty Council, and also please voice your opinion, any feedbacks we would like to have. Appreciate it very much. So with that, I think our meeting is going to be adjourned. Thank you, everyone, and hopefully you have a wonderful summer.
Thank you so much. I wish I could see your face. One day. All right, take care. Thank you again.
Goodbye.
Goodbye.